Hello, we'll be talking about APGN, which stands for Acute Proliferative Glomerulonephritis. It is also known as Infection Associated Glomerulonephritis, Post-Streptococcal Glomerulonephritis, Post-Infectious Glomerulonephritis. Now, if you look at these names for a second, glance at them, you would understand this a lot about this disease. First, let's elaborate APGN, which is acute proliferative glomerulonephritis. You understand that there would be proliferation of some cellular population, some cell population. Uh, let's write down the definition. You'll understand that way. Diffuse proliferation of glomerular cells associated or accompanied with leukocyte infiltration. Now, the triggering factor for this leukocyte infiltration is an immune complex. Immune complexes. Okay. So the proliferation would be of the glomerular cells and leukocytes. Technically, this causes hypercellularity, which you can visualize very well. Adjacent to this is the normal glomerulus, which is normocellular. Now you can see that there is a lot of cellularity here, which could be again. I'll discuss it in morphology in more detail. In a crux, in a nutshell, this glomerulus is hypercellular. Okay. Now let's talk about etiology. Again, if you elaborate the other names, post-streptococcal. Okay, this is caused by group A streptococcus. It can also be caused by other microbes, but primarily it is caused by group A streptococcus, which is Streptococcus pyogenes, especially the strains 12, 4 and 1. These strains are nephrogenic strains. Strains primarily causing glomerulonephritis. Okay. Just a reminder, this is beta hemolytic. Okay. Now about the pathogenesis. Remember that this is type 3 hypersensitivity because immune complexes are involved. Okay, immune complexes are involved. So there would be an antigen again, and there would be antibody against that antigen. Antigen. What is the antigen here? It is SPEB. What is SPEB? It is streptococcal pyogenic exotoxin B. Now, this particular, even before that, there's typically the presentation would be of a young child with a sore throat. That the term for it is streptococcal pharyngitis. Okay, after about 4 weeks, two to four. Anyway, there would be manifestations of glomerulonephritis like mild proteinuria, hematuria, mild to moderate hypertension, etc. Not in fever, nausea, oliguria, etc. Okay, so this SPEB, streptococcal pyogenic and exotoxin B, this accumulates or deposits on the subendothelial side. This is the subendothelial side. Again, This is the endothelium, this is GBM, glomerular basement membrane, and these are the visceral podocytes or the visceral epithelium. So this would be the subendothelial side, this would be the subepithelial side. Okay, now this is the peptoxin. Antibodies are produced against this antigen, and immune complexes are formed on the subendothelial side. Now they migrate into the subepithelial side. Okay. Now they form subepithelial humps. Okay, this is the pathogenesis. Now let's talk about the morphology. Again, as I've already mentioned briefly, the glomerulus is hypercellular. Now the hypercellularity is because of endothelial proliferation, glomerular cell proliferation, mesangial proliferation. Okay, now this is the immunofluorescence. You can see that it is very granular. It is not linear like this. It is granular, like islands of deposits. Okay, it means that this is granular deposits of IgG, C3, and very rarely IgM. Okay, now let's talk about the electron microscopy. Again, I have already mentioned that there are some subepithelial humps, right? So you can see that this is the subepithelial hump I was talking about. This is the subepithelial hump. This is the endothelium. This is the glomerular basement membrane. This is the endothelial space. This is the subepithelial space, and these are the visceral podocytes. Okay, let me rub all this. This is the part where you have to focus, which is the subepithelial hump. Okay, these are electron dense deposits. Okay, there is not much we are left with. Let me discuss 2 points about serology. A rise in anti-ASO titers. ASO is anti-streptolysin O. O for oxygen sensitive. Okay, this is not micro. Okay, fine. Anyway, there will be a decrease in C3 levels. Yeah, a little about clinical features. First, it is almost always a young child. Not almost always, but yeah, It's most usually a young child with a sore throat, history of sore throat, fever, oliguria. After lab investigations, you would find that there is hematuria. If the hematuria is microscopic or gross, there will be cola colored urine. Cola colored urine. There could also be mild proteinuria. Again, this proteinuria is non-selective. Sore throat leads to PSGN. That may lead to chronic glomerulonephritis, or that may lead to RPGN. I'll cover RPGN in the next video. Thank you. That was it. Thank you.